I'm happy to introduce today's speaker, Sruthi. I'm her advisor, and I've known her a long time, but I still cannot pronounce her last name. I apologize for that. I think you all know I have some sort of a speaking disorder, which makes it impossible for me to pronounce certain names, including my own, but Sruthi's for sure. Sruthi, of course, is one of our PhD students in her second year. She actually is here for the second time because she got her master's here a few years back. After her master's, she went back to India and worked at GE Healthcare. Got a lot of really great experience. Before her master's, she has a bachelor's of pharmacy from India, from Osmania. Is that how you say it? Osmania. So, of course, her interest is pharmacoepidemiology. The project she's presenting today is something she's worked with Todd Lee and also Min Ju, who unfortunately neither of them are here today. But this actually, I think, is pilot work that went into an R01 application that Min submitted and got funded for. So congratulations to Min, and Todd's on that, and so is Lisa. And thanks to Sruthi for her work in the pilot study, but looking forward to hear it.
Thanks.
And please fill out the evaluations. There's a new form this year, a little bit easier, I hope, but it's helpful for the students.
All right. Thank you for that introduction, and thank you everyone for coming in today. Today I'm going to be talking about a research project that I worked on last fall, looking at spirometry in the diagnosis of COPD and hospitalizations for acute exacerbations. Our research team included clinicians from College of Medicine. Travis Yamanaka was the principal investigator on this study, and we also had Lauren Estep, Jessica Lau, and Minju. Todd Lee was my Dr. Todd Lee was my faculty advisor, and I was the research assistant analyst on the project. So quickly, my talk is structured into background, methods, results discussion with little room for questions in the end. So I'll request that you save your questions for the end. I'm sure we'll have time to go over them. As background for the talk, I wanted to introduce spirometry. I'm sure most of you know it, but it's a pulmonary function test that's used to evaluate patients with respiratory symptoms. It's an office-based test, and it measures forced expiratory volume in 1 second and forced vital capacity. And then that ratio is an important parameter to detect limitations in and any severity of airflow obstruction. Spirometry in the diagnosis of COPD, according to guidelines. There are multiple international guidelines that place spirometry as the gold standard in the diagnosis of COPD. They recommend the use of spirometry to diagnose airflow obstructions in patients with respiratory symptoms or any patients at risk. They do not recommend the use of spirometry for screening asymptomatic individuals. Now, symptomatic individuals typically are those that have exposure to smoking or environmental pollutants, who have family history of COPD and present with wheezing, shortness of breath, chronic cough, or limitations on exertion. In the US, National Committee for Quality Assurance, NCQA, developed a quality of care measure, which says that spirometry is a key diagnostic test that must be performed within 2 years prior and 6 months post a new diagnosis of COPD for that particular diagnosis of COPD to be referred to as a spirometry-associated COPD diagnosis. The reason all these societies recommend the use of spirometry is that it appropriately classifies severity of disease, and information from the test can then be used in making treatment decisions and therefore improving health outcomes in COPD patients. Having said that, these are the guidelines, but practice, the situation is very different from guidelines. And despite the guidelines, spirometry is not used very frequently to confirm COPD diagnosis. This is a slightly old study from about 10 years ago, but the rate of spirometry documentation in COPD diagnosis was as low as 26 to 38%. And surveys conducted showed that very few physicians would order a spirometry when they come across patients who are smokers that present with respiratory symptoms. A large proportion of cases till date remain confirmed only based on subjective assessment on clinical grounds. And specialists are more likely to use a spirometry than primary care physicians. Potential negative consequences of underutilization of spirometry include over-administration of therapies and increased costs in health, and resulting increased costs in healthcare utilization. So having said that, the gap identified was that there is no that currently there was no evidence talking about the impact of using spirometry to confirm COPD diagnosis on health outcomes. So our question was, among new diagnoses of COPD, is the use of spirometry associated with differences in hospitalizations for acute exacerbations of COPD? Breaking it down into the PCOTS framework, the population that we looked at was commercially insured adults residing in the United States. Our exposure was spirometry-associated diagnosis of COPD. Our comparison group was new diagnoses of COPD that did not have a spirometry associated with them. The outcome that we looked at was time to first hospitalization for ACOPD. We looked at a time frame of 2009 to 2013 based on the data that we had available to us. And this was conducted in the Truven market scan databases. Before we went into the data, we conceptualized that factors such as age, gender, facility where diagnosed, the provider diagnosing the COPD, severity of symptoms, comorbidities, and prior utilization may confound any association between spirometry-associated diagnosis of COPD and hospitalization for ACOPD. So like I mentioned, like you might have gathered from the PCOTS elements, this is a observational study. We conducted a cohort study using secondary data or retrospective cohort study. The source for my study was Truven market scan databases, which most of you are familiar with, but quickly, it's private sector health data from over 350 payers. That includes person-specific healthcare utilization, inpatient, outpatient encounters, and prescription drugs, and expenditures from a selection of large employers, health plans, government, and public organizations. The data that UIC currently holds goes from 2008 until 2013. And we have access to two databases: commercial claims and encounters and Medicare supplemental. Commercial claims and encounters includes person-specific utilization data for active employees, large early retirees, COBRA continuees, and dependents in employer-sponsored plans for individuals working with large employers. And the Medicare supplemental file includes Medicare-eligible retirees with employer-sponsored Medicare supplemental plans. It mostly captures fee-for-service data. The way we set up our study with respect to the data that we had available was as follows. We used data from 2009 until 2013. We looked for an index diagnosis of COPD or a new diagnosis of COPD between 2011 and 2012, January 2011 and December 2012. Once we identified their index COPD, we made sure that it was a new diagnosis by looking back 2 years and confirming that they do not have any codes for COPD. And then we looked back, the period of look back was 2 years before their index diagnosis. And in this period, we made sure that they did not have any COPD. And this was also the time during which we ascertained their spirometry. And the follow-up started on the date of the diagnosis, and we followed them until they had an event, hospitalization for ACOPD, or it was the end of enrollment or end of data. So in order to enter our study cohort, patients had to have new diagnosis of COPD between January 2011 and December 2000. Sorry about that. That's December 2012. They had to be between 40 and 88 years of age. They had to be continuously enrolled in 2 years prior to diagnosis, and we did not include patients that had an overlap of COPD and asthma diagnoses. Like I mentioned, spirometry, the use of spirometry was determined in the 2-year period prior to the diagnosis of COPD. Patients had to have at least one procedure code for a breathing capacity test, patient recorded spirometry, evaluation of wheezing, or a pulmonary stress test. These codes we identified this list of codes based on what was previously used in literature to determine spirometry associated COPD diagnosis. The outcome that we were looking for was hospitalization for AECOPD. So we both measured whether or not they were hospitalized and what was the date of first hospitalization for AECOPD after their index diagnosis. This was done by looking at primary or secondary discharge diagnosis codes that indicated acute exacerbation of COPD. Again, we selected the ICD-9 codes based on an algorithm that was developed previously to capture acute exacerbations in patients aged over 40 years. These codes were reported to have a positive predictive value of 81.2% and an NPV of about 94%. Along with the exposure and outcome, we also looked at several other covariates. We captured age at diagnosis of COPD, and we categorized it into tenure categories based on the distribution that we had. We captured gender, we captured region, which in the TrueWin data is not central US, northeast US, southern US, western US, and an unknown region. We also captured the quarter year of index COPD diagnosis, given that the study ranged across years, so we wanted to look at any potential differences by change in practice. We captured whether or not the COPD diagnosis happened in an outpatient setting, and whether or not the COPD diagnosis was confirmed by was done by a pulmonologist, a specialist, or not. In addition to that, we also captured Charlson Comorbidity Index and categorized this variable as a CCI score of 1, 2, or 3 or more. Additionally, the clinicians on our research team wanted to look at diseases that were not captured in CCI that could impact the outcome. And so we went ahead and also gathered information on the presence of congestive heart failure, atherosclerosis, valvular disease, pulmonary circulation disorders, and a host of other diseases at baseline, so in the 2 years prior to their index COPD. We also looked at a count of the number of times patients in the cohort visited emergency room, had an outpatient encounter, or were hospitalized in the baseline period. We also looked at the use of respiratory medications at baseline, specifically looked at beta agonists, anticholinergics, methylxanthines, corticosteroids, and phosphodiesterase inhibitors. So for our analysis plan, the first thing that we wanted to do was compare characteristics at baseline between patients that received a spirometry or had a spirometry-associated COPD diagnosis versus no spirometry. We described the median time to first hospitalization, and we compared the survival in two groups using the log rank test. And then we looked to determine the association between our exposure and outcome, adjusting for the influence of confounders using Cox proportional hazards. And for our model building, we used a combination of change in estimate and clinical relevance as the criteria to select covariates in our model. So moving to our results, this is a flow chart describing the entry of patients into the cohort. We started with about 762,000 patients that had an incident diagnosis of COPD between January 2011 and December 2012. And then we excluded 45,848 patients that were either younger than 40 or older than 88. We excluded patients older than 88 because there were several questions about potential benefits of spirometry given shorter life expectancy at that stage, what else might be going on in such older patients, and several other factors associated with very elderly patients that made us choose the range of 40 to 88. So once we excluded them, we had 716,000 new diagnoses of COPD. Once we had them, we then excluded about 24,000 patients because they also had an overlapping diagnosis of asthma. We excluded a huge chunk, 416,000, because they did not have continuous enrollment in the 2 years prior to their baseline. 2 years prior to their index COPD or in the baseline. And there was a very small number of patients that I call this bad data, but essentially what was going on was a very quirky thing that they had an index COPD diagnosis after their last date of enrollment. It shouldn't have been the case, so we excluded them. So in the end, we were left with about 275,000 patients. The exact number was 275,197. So when we compared the patients in our cohort, we compared the spirometry group versus the no spirometry group. What we found was that overall, 31% of new diagnoses of COPD were associated with spirometry. The spirometry group was younger than the group that did not have a spirometry-associated diagnosis. And they were also more likely to be from the northeast part of the United States. Now, given our sample size, everything we found had a p-value of 0.0001. But there were only two factors that were not statistically significant, and I've called them out by an asterisk on the slide. So about 31% had spirometry. The spirometry group was younger and more likely to be from Northeast in terms of demographics. In terms of their index COPD diagnosis, we saw that this was confirmed also by literature. 16% of the COPD diagnosis in the spirometry group were by a pulmonologist versus only 3% in the no spirometry group. In terms of comorbidities at baseline, the group that received spirometry were sicker, and they also had more respiratory conditions, sleep apnea conditions at baseline compared to the non-spirometry group. They also tended to utilize healthcare resources more, as captured in the number of times that they visited an emergency room or had outpatient encounters at baseline. So as you see, 48.6% in the non-spirometry group had no ER visits in the baseline versus 51%. And in terms of outpatient encounters, there's a, if you can see the bottom group, the group that received spirometry were more likely to have more than 61 visits in the 2 years prior to their diagnosis. Now, one thing to note is that these are outpatient encounters. This does not mean that they were always seen by a physician. They just showed up in our data as having visited a facility. So this could be lab visits or actual outpatient visits. In terms of medication use at the baseline, the patients in the spirometry group had more medications at baseline than the non-spirometry group. This was surprising to the clinicians on the team because this is at a time when they were not diagnosed with the COPD. So they're already receiving a lot of medications prior to the diagnosis of COPD, which is not a guideline concordant behavior. And also the use was more in the spirometry group, some of which can be explained by the fact that the spirometry group also had more, was also sicker at baseline in terms of the respiratory conditions. In terms, yeah.
Sorry to interrupt. Can I just ask a quick question on that? Because they were surprised by this, did they look at when those prescriptions were, if they were very close to the time of diagnosis, or if they were very far back, or did you not?
No, we did not look at that. Okay. But that would have been something to look at, for sure. Yeah.
Thanks.
Yeah. In terms of AECOPD hospitalizations, overall, there were about 9,100 events in the cohort. That's about 3.3%. The number of events in the spirometry group was 3,057 or 3.5%. And in the non-spirometry group, that was 6,087 or 3.2%. Among those that were hospitalized for AECOPD, the overall median time to event was 245 days. And the IQR around that was 82 to 459. In the spirometry group, the time to hospitalization was 252 days, the IQR being 86 to 464. And in the non-spirometry group, that was 225, 79 to 457. We tested for equality of survivor functions in the two groups. The p-value was significant at 0.01 or 0.02. In terms of the crude hazards, the crude hazards ratio that we observed was 1.05, and the confidence interval around that was 1.01 to 1.10. The final model, like I said, we used a combination of change in estimate more than 10% and clinical relevance as criteria to select our covariates. And the final model included age, gender, resource utilization, comorbidities, use of respiratory medications, and outpatient or not, or pulmonologist or not. Now we used a Cox proportional hazards model to model the association, and for that it was important for us to look at the proportional hazards assumption. In order to look at the proportional hazards assumption, we compared the survival curves between the spirometry group and the non-spirometry group. And what we also did was look at a global test using Schoenfeld residuals. The p-value for the global test was 0.12. A non-significant p-value on that test indicates that the proportional hazards violations were that the proportional hazards assumption was not violated. When we put these covariates in our model, the adjusted hazards ratio that we saw was 0.83, and the confidence interval around that was 0.79 to 0.87. So this implies that the use of spirometry, or the rate of hospitalization for ACOPD in the spirometry group was lower compared to the non-spirometry group. And it's a small reduction, it's a minor reduction in the rate of events. And this was our Kaplan-Meier curve. But the scale is off, but we only did that because there were very few events. There were 9,000 events. So the scale starts from 0.97, so don't hold me to that. But that's only to show the survival curves between the spirometry and the non-spirometry group. And this is adjusting for the final covariates in our model. And as you can see, the spirometry group had a lower rate of hospitalizations compared to the non-spirometry group. Wow, I went really fast, I guess. So in summary, what we found was that patients with spirometry were sicker. They received more medications at baseline. They had higher utilization of healthcare resources. And they were also more likely to be diagnosed on their COPD by a specialist. And adjusting for these differences, the use of spirometry was still associated with a minor reduction in the rate of hospitalization for acute exacerbations. So in terms of, I divided the discussion section into a discussion about the methods that we used and a discussion about the results that we found. This slide is about the methods. So we, in terms of definition of exposure, right? So the NCQA measure defines a spirometry associated COPD diagnosis as having a spirometry in 2 years prior to COPD diagnosis to 6 months after. Now we only looked for spirometry in the 2 years prior. We did not look for spirometry in the 6 months after. Now that was done because we had to make a trade-off between, okay, so if we ascertain COPD spirometry in the 6 months post-diagnosis, when do we start our follow-up? We either start our follow-up at after they received spirometry, in which case the comparison group, you can either start at index COPD diagnosis, which kind of makes it different, or you can also start them at a random date that was kind of matched to the spirometry, which will then introduce some immortal time. So we decided that a potential misclassification is something that we were more comfortable with than having that discrepancy in follow-up. So there could have been some new diagnosis of COPD that would truly spirometry-associated diagnoses, given that they had their spirometry after their COPD diagnosis, which we have classified as no spirometry, and that might weaken the association that we observed.
Sruthi, did you look to see how many, at least look to see how many patients that was the case for?
Yeah, we did. Oh my gosh, I should have that in my appendix, but I don't have that number. But we did look at that.
Ballpark, do you remember or no?
I should remember that,
That's
but
okay.
I'm sorry.
That's okay, don't worry.
No, but we did look at the distribution before making this decision.
Okay, that's fine. Don't worry.
Sorry.
Don't worry about it.
I had one job. Sorry. The other thing with the design, with the observational nature of the study, is that we're not able to tell if whatever minor improvement that we saw was truly because of the spirometry, which could have happened in the 2 years prior to their diagnosis, or was something systematically different in the care that these patients were receiving. Was it their physicians? Although in the hypothesized pathway for that association, we did assume it was a quality of care, that the spirometry was acting through quality of care. But there's no way that we can attribute that. So that was a discussion on my methods, on our methods.
Can I just ask one thing? Also, I know at least here, sometimes the physician will refer the patient for spirometry, but the patient never goes. You don't have that, right? You were going by if they completed the spirometry.
If they had an office
primary care
space.
settings.
Yeah.
Because the primary care settings, oftentimes you have to go to a different lab in order to get it.
Yeah, and if they did get it, then it would be coded as a patient-recorded spirometry where they bring back the results.
So there may be some people that were actually referred for spirometry, but they did not go.
That could have been the case, and they will be classified as no spirometry. I don't think we have the referral captured in the code. We have the results captured. So in terms of the results, I mean, we saw that 31% of COPD diagnoses were associated with a spirometry recording. Now, the study that I showed earlier in my slides, which said that the rate of spirometry documentation in COPD was 26 to 38, that was 10 years ago. And 10 years later, that rate remained the same at about 31%. So that is disappointing in pulmonary and critical care field, at least. The question is really relevant in pulmonary care, and it benefits from any investigation of this because more recently, in 2013, when a survey was conducted on primary care physicians in the US, 76% said that they still use clinical judgment, a subjective clinical assessment, to confirm a COPD diagnosis. And previous research has shown that the use of subjective judgment yields less than 50% accuracy in diagnosis of COPD. So COPD is often overdiagnosed, underdiagnosed, and misclassified in the population. And that could go different ways in terms of utilization, administration of medications, in terms of costs. And what's of importance here is that that spirometry is the only available diagnostic test. The guidelines refer to it as the gold standard, right? To confirm presence of irreversible airflow limitation. And it's just puzzling, at least to the clinicians on our team, as to why the one diagnostic test available is not used in confirmation of the COPD diagnosis. So Dr. Minju, who was on the research team, also conducted qualitative studies before to understand what some barriers were. So based on some focus groups that she did in the primary care setting, the following themes emerged. So most primary care physicians had a belief that spirometry is not always needed to diagnose COPD, which is completely different from what the guidelines say. They also say that sure, they may order a spirometry once a patient presents with symptoms, but at the time that the patient comes to them with the symptoms, they start their trial of medications. They start the use of respiratory medications, and they're unlikely to change that irrespective of what the spirometry results say, which could then lead to over-administration of therapies. Maybe they don't require to be receiving so many respiratory medications, but they still do. And then another belief that emerged from those focus groups was that there's no evidence to show that spirometry makes any difference. Using the spirometry makes any difference. So that's why our team felt that this was a question that warranted a study, that any evidence that we can show, that any evidence showing an improvement in health outcomes might actually start convincing physicians to uptake spirometry. But I know this is one study, but then from multiple studies, if there is similar evidence, maybe that's what leads to change. So in order to corroborate the findings, if I may, Dr. Minju is actually conducting a randomized control trial, as Dr. Shumov mentioned. So we're looking to see if we find some similar results. Yep. That's actually the end of my talk. So thank you, and questions. Dr. Cato first.
Yeah, just a question. So did you investigate if there's any heterogeneity benefits of spirometry in different patient populations?
We did not look at subgroups, so no, we did not look for any effect modification. We let the clinicians kind of take calls on if they wanted to look at any subgroups, and that was not something that came up during this study. So no, we didn't look at. Yep. Greg?
Nice work. So what were the comorbidities that were included in the model?
So we did not include, okay, I don't have it, but I can tell you. We did not include the CCI, but we included all the other comorbidities all these other comorbidities that we selected.
So all of those were included?
All of these were included. Yep. All of these were included. There was one other that was in the protocol. What was it? Chronic pulmonary condition. That was also something that we measured, but everybody had it, so we dropped that.
Okay. I mean, I think the one that I was thinking about the most among this list of comorbidities was the obesity one. When you showed the prevalence of that, it seemed really low.
Mm-hmm.
Do you think that could be because just the sensitivity of using ICD-9 codes for obesity? It seemed.
Potentially. I mean, we use the codes that are recommended by ARC, but potentially.
Were those variables selected a priori, or was it based on the data?
Yeah. Well, no. Sorry. Were selected to be included in the model.
Yeah.
That was a combination of change in estimate and clinical relevance. Most of the comorbidities, they met both criteria. The only thing that did not change in estimate, but we included anyway because of clinical relevance, was age and gender.
How about the CCI? How was it dropped?
It could have been that it did not change, but I'm not exactly sure why we didn't include that.
It seems like it's fine.
Yeah.
I was just wondering, so did you include all the variables that change the estimate by more than 10%? So just want to be clear.
Yes.
So every single one of them that moved the bar were included, and half of it then you decided on clinical variables.
Yeah. So we also went through the exercise. Actually, since we have the time, maybe I can pull up a document from my box. We also went through the went through the exercise of, okay, so there were 19 variables that changed the estimate and were clinically relevant, right? Oh, this is not me. Sorry, just give me 1 second. I'll pull up something relevant. Oh, sorry. Right. So I also went through the exercise where everything that was clinically relevant and changed the estimate was the gold standard model, and that included 19 covariates. And what I also did was like kind of remove them, change the combinations of that to see how that impacted the adjusted hazards ratio, and it did not change much. If I could have chosen this model with just the strongest confounders, SABA, use of steroids, other lower respiratory disease, age, and gender, and that would have yielded a narrower confidence interval, but there was no change. I could have used 19 covariates or 6 covariates, and I had similar findings. Yeah. Sure.
Did you try to look at mechanisms that might be causing this? Like, did you try to look and see if there was more prescribing of certain kinds of drugs, or?
The entire mechanism was this giant block that we called quality of care, and we did not look at any of the
The elements in.
Could you go back to your, was it causal model or conceptual? Just to... So in between those, the spirometry and the hospitalization or exacerbation, do you think it's increased quality of care because you have this information?
Yeah. So if you look at the last point on the slide, so first thing that it does is confirms the presence of irreversible airflow limitation, or like confirms the diagnosis of COPD. And then it can also help you with severity of COPD, classification of severity, which can then impact treatment decisions and health outcomes. So that's the mechanism that we had, the whole chunk that we call as quality of care, that we hypothesized would be systematically different between those that received spirometry versus not spirometry. I know, sorry, Kellen has been, yeah.
I was just wondering, because the guidelines say that it's for diagnosis, everyone should get it, right? That's the guidelines.
Yes, if you present with symptoms, so if you're a symptomatic individual with risk factors, then you should use the spirometry to confirm. But they do not recommend using it as a screening mechanism on asymptomatic individuals. So if they do not present with wheezing, shortness of breath, chronic cough.
Yeah. So I was just wondering, and I know guidelines are just recommendations and can be based on other like experts or whatever, but was there evidence that, like, what informed that recommendation in the guidelines? Like, is there evidence that, because I was just, the fact that a lot of the providers don't even think it's necessary.
Yeah, you're right. So the guidelines weren't based on like
any studies.
Strong evidence. They were just based on, okay, there's a lot of overdiagnosis, underdiagnosis, there's a lot of medication that is being given on subjective assessment and factors like that. As far as I know, I don't think there have been any stronger studies that looked at the association. Rachel?
Just going back to the population that were on, for example, the SABAs and LABAs before the baseline diagnosis, was there any sensitivity around either shifting their time of diagnosis or excluding them and seeing how that impacted it?
I didn't think of that. No.
I just, not a pharmacist, but there aren't that many reasons they would be on those drugs.
Yep.
So,
Given that we excluded asthma population, right? So, but they did have more respiratory conditions. But I don't know.
and you adjusted for a lot of that in the model, but just thinking to all of the other things that could be going on and if their treatment trajectories could be different, that might be something too.
Yeah, that might be something we can explore. I'm going to take that point back. Thanks. Yes, Stefan.
Yeah, compared to patients received spirometry, those who do not receive spirometry has a huge variation. They can be either not sick at all because not necessary or too sick. And also I'm considering those newly enrolled in the program, so they already have a diagnosis, so the doctor might not think it's necessary. So this is my first question, how do you treat heterogeneity?
So some of that was controlled for in the design of the study, in that we selected participants that did not have, that had to have at least 2 years worth of data prior to their diagnosis, and in that 2-year period, they should not have had a COPD code. So it can't be that there are new members who may have had like a history of COPD, and that's something that may not have happened. Sorry, what was the second point about?
Yeah, for those, because they might not be recorded even spirometry has been carried out. It's like a pen-like device, maybe even in specialized are more able to code this in their record.
Yeah, I mean, that's a flaw with using this kind of data, right? So we're hoping that some evidence emerges from RCT where we're very confident about the use of spirometry.
And I think the value of spirometry is not to perform a diagnostic test, but to compare the value of these different measures and see whether there's improvement of treatment. So have you seen a switch of treatment outperforming like 2 or 3 times of the time variable in terms of treatment pattern changes in the patient?
No, that's interesting, but it was beyond the scope of this particular study. But that's interesting. Thanks.
You could, again, go back to the same thing, but if you've got that cohort of patients who were on drug, pre-post spirometry, look at if they change therapy.
Yeah, we're good. Thank you.